Hello everyone, it is my first time doing this virtual hour on Instagram, so bear with me for the delays and I hope this is helpful. So I have been doing this just because I've been getting so many queries through email, through DMs about various questions, and I want to answer them all, but it's so hard to do that individually. So here I am answering all your questions. So some of these are going to be clinical, meaning what can I do if blank is happening with my pelvic floor. Some of these are going to be more logistical. I did have a bunch of questions, at least 2 different people asking about how can I get started in pelvic health as an OT, what courses do I take, so we'll answer that also. If you have any questions, do throw them in the chat and I'll be happy to get to them. And I will be recording this so we can have access to it both on Instagram, or I'm hoping I can record this because technology is not my strongest suit, but I'm going to do my best. And if that recording happens, we will have it for viewing on YouTube later. So that being said, let's jump in. Hello, Dr. Melanie. I'm very happy you're here. I'll try and check in with everyone who is watching. So a very interesting question I got, and that I think will be helpful to a lot of listeners, is can my child's bedwetting be related to the pelvic floor? And can it improve with pelvic floor therapy? And the answer is yes. So often when bedwetting happens, when it becomes pathology instead of normal, that is, a child is not potty trained at night beyond say 4, 5, at most 6 years of age, we definitely should be having a conversation with the pediatrician, and they should run most likely a hormonal panel. It could be totally hormonal, in which the production of ADH, anti-diuretic hormone, is a little lower. That is something the gynecologist, I talk about gynecologists all day, the pediatrician can look at. But however, there could be other things going on. So in the wheelhouse of pelvic floor therapy and bedwetting in children, or honestly, children having accidents of their bladder, accidents like poop accidents in school, that can very, very often be addressed by a pelvic floor therapist. Of course, I must say not all pelvic floor therapists treat children. Some of us do. Also, the pelvic floor therapy for children looks a little different, meaning for children under the age of 18, honestly, I was a child before, until I was like 21 or 22 in my head, but for people under 18, most therapists do not do anything internally because yes, everything, that child has to learn their sexuality, and honestly, for their first experience or possibly first few experiences in that area, in their genital area, to be a stranger, a clinician, that is just too much of a violation. So I will treat children through external strategies, basically parent coaching. I will also teach parents some hands-on techniques that they can use, or even if the child is old enough, like 8 or 9, to have them feel the contraction or the relaxation in that genital area. But no, we don't do anything internally for children. But however, so accidents both of the bowel and the bladder during the daytime or the night time can very, very often be addressed by pelvic floor therapy. Also, I must say, a common culprit during with these accidents, especially bedwetting, and with older children who were toilet trained and then went back to having accidents, a big culprit in that situation is often constipation. Now, a lot of us don't think that we or our children are constipated if we poop every day, but honestly, if your poops are not those nice, smooth, sausage-like poops without any cracks, you are borderline constipated or constipated. So even if it has some cracks, you're probably dehydrated, or if you are someone who poops multiple times a day and your poops are closer together, meaning the interval between 2 poops is 2 hours or less, then you probably did not empty all the way the first time. And that often happens with children also. And honestly, in school, there's another layer of Often school bathrooms may not be clean. The child may be holding in their poop, not wanting to poop outside the home, outside a familiar environment, which leads to accidents in the school, which leads to constipation, which can also lead to bedwetting at night time. So pediatric pelvic floor therapy is a little bit of a different game. So not all of us do it. I will treat it externally through parent coaching and some hands-off techniques. So that was question number 1. Question number 2 that we had was, how do I get started in pelvic floor therapy? So now this will vary from country to country. I know there are people in India watching and professionals from across the globe. So it really depends upon scope of practice. In the US, most pelvic floor therapists are occupational therapists or physical therapists. A good majority are physical therapists, which is why it is often referred to as pelvic PT. But honestly, a lot of occupational therapists do this work as well, including myself. So I really like to call it pelvic floor therapy. That way, when someone's trying to find services, they know to look for more professionals than just PTs who are doing it. Also, in some of the trainings I've taken, there have been chiropractors present. Depending on the state, chiropractors may or may not be allowed to do anything internally, meaning inside the vagina or inside the rectum. There are nurse practitioners, nurses, and even a DO. There was a wonderful DO, and shout out to Dr. Palakal James up in Tallahassee, or no, Jacksonville. She's wonderful. She's a DO who has done pelvic floor training. So some wonderful providers doing pelvic health. So no matter what your profession, make sure it's in your scope of practice. And the most common way to practice in pelvic health is through the Herman and Wallace Rehabilitation Institute. They offer in-person and online trainings, and online meaning it's live. It's not like you are watching something like a recorded video, excuse me, and you have a TA on site coaching you through techniques. So Herman and Wallace Rehab Institute is the most common way to get started in pelvic health. There are other trainings that are now much more, that are coming out, which is wonderful. There are 2 OTs doing wonderful work for other pelvic OTs. Lindsay Westel, she's called the Functional Pelvis, and excuse me. And also Laura Rowan has a manual techniques course that she is doing. Both of those I haven't taken myself, so I can't speak to that, but lots of great reviews from both of those courses. So either Herman and Wallace, or if you're doing the OT route, if you're an OT, you can check out Lindsay Westel's Intro to Pelvic Health, or Laura Rowan's, I think it's called PRMATT. It's manual techniques. Also, I'm sorry, my throat is acting up. The APTA, the American Physical Therapy Association, has a pelvic rehab section. I know a lot of PTs start off that way. However, if I have understood feedback right, even the PTs who took the APTA courses preferred the Herman and Wallace courses. Honestly, with Herman and Wallace, I've had really good experience through everything from my introductory training to advanced practice techniques. So I hope that was helpful as far as the question about how do I start in pelvic health. Let's see, what else did we have? We had a question about how long should I wait postpartum before starting treatment for diastasis. Now, diastasis is when a separation happens in the abdominal muscles. And this is very, very common in pregnancy. People think it's only pregnant people that get diastasis, and that's not true. If someone has a lot of abdominal weight that they carry, that can cause separation of the abdominal muscles. Honestly, all of us in the truest sense have a small diastasis, a separation in these muscles, because our most superficial muscles, our abdominal muscles, run from the bottom of our sternum down to our pubic bone, right? And these are naturally separated a tiny bit, like less than a finger width, right? So what happens during pregnancy, to make room for the baby to grow, for the belly to grow, these muscles, the recti, the rectus abdominis muscles, that is, or recti, plural, they will stretch lengthwise and they will start separating to make room for baby. So when this separation that happens here doesn't quite close up, that is when we diagnose DRA, or diastasis rectus abdominis postpartum. That being said, if you carry a baby to term, meaning if you have a baby, if you at least reach 36 or 37 weeks of pregnancy, you are going to have a diastasis. Now, it becomes pathology or something to fix when that separation stays open for a long time. And I apologize if those little beeps came through. There we go, that should fix it. So yes, it's a problem when it doesn't close. And when I say close, honestly, some of us may have a separation of up to 2 finger widths postpartum. So the line, or when is diastasis diagnosed? Diastasis is diagnosed when there's a separation of at least 2 or more finger widths when measured in the midline. And also your therapist probably will check. They will not only check for width, they will check for depth also, because the muscles have to heal from the inside out. Your deep core muscles need healing as well. So definitely, if someone's checking you for diastasis, ask them how my deep core is doing. Ask them what's the depth feel like, not just the width. So yeah, for diastasis rehab, definitely start doing some core exercises in pregnancy. You do not have to wait till after baby comes to start this. So during pregnancy, you definitely should be doing some pelvic exercises. You should be doing some core exercises, and keeping up with this is going to help you postpartum. So in postpartum, you can get started with those gentle, easy strengthening exercises of the core, of the pelvic floor. Day 2, day 3 postpartum. That being said, if you had a C-section birth, please let's not start working our abs just yet, because we don't want to have those stitches open up. We want a nice, beautiful scar, not one that is bumpy from moving too soon. So if you had a C-section, I would say definitely wait till your 6-week check before starting to do some core work. Not 6 week, that's a little if you're doing it yourself, wait till 6 weeks. If you're working with a pelvic floor therapist, you can start sooner, because then we can assess and address accordingly what you can do and what you should do. And that can be as early as 4 or 5 weeks. So yeah, you don't have to wait for diastasis rehab. You start it off during pregnancy, and you can start with a vaginal birth, these exercises, as early as day 1 or 2. Though I hope you make some time for rest. You just need a human being. You deserve to rest and not just exercise. But yeah, you can start off soon with a C-section. Wait a minimum of 4 to 6 weeks, because we don't want our scar to be bumpy and not so nice. And beyond aesthetics, it goes beyond aesthetics, because if it's bumpy, it's because alignment is not great on the inside. So diastasis rehab, that's the timeline. If you are using a program, there are some really good online ones out there. The Mutu system is a good one. The Tapla technique is horrible. I don't think anyone's using that now, which is great. Restore Your Core is a good one. All of those, again, wait at least 6 to 8 weeks and get your pelvic floor checked to make sure you are using the right muscles. Because, you know, someone can instruct you in a wonderful program online, either like, you know, there's so many wonderful fitness professionals, perinatal professionals doing great education on Instagram, on other platforms, TikTok. But, you know, you may not be sure you're using the exact right muscles till someone feels it and they teach you to feel it and be like, oh no, tighten here, let's relax there, give me a good contraction here, or let's open those sit bones, you know, cues like that typically are not coming through an online training. So if you choose to use an online program like Restore Your Core or the Mutu system, definitely check in with a pelvic floor therapist at least 1 or 2 times. So I hope that helped. And let's see, the last question, or one of the last questions we had, was a very interesting question, and I'll be very honest and say I had to do some digging myself, just because I have never treated a patient myself with this condition. It is extremely rare and it can have a lot of impact on someone's life. This condition is called MRKH. It is, and what can you do with MRKH as far as pelvic floor therapy? So I'm just going to pull this question up because someone had sent in, let's see, I'm going to pull this up. So yes, MRKH is actually a cluster of symptoms. The most obvious sign being, or the most significant sign for diagnosis being, that this person is genetically female. It's a female baby. They have externally normal genitalia, meaning their vulva looks normal. They have a normal looking vaginal opening. However, the vagina is not formed completely, or it may be formed completely, but the uterus is absent. So it occurs to different degrees. Basically, the reproductive tract is not well formed. In some cases, the uterus may be completely absent. In other cases, the uterus is partially formed. In some cases, the vagina may be almost absent or completely absent except just the opening. Or in other cases, the vagina has some length but not a normal length to have something inserted, be it a tampon or a penis for intercourse. Also in this condition, the ovaries are normally present. So hormonally, externally, the woman may be normal, like she'll have secondary sexual characteristics like breast development, pubic hair, but the vagina won't have any depth. So honestly, this being such a specialized condition, it was a little too much to explain just on live here. So I wrote a whole blog article. I link it in my bio, and if I'm hoping, fingers crossed, that I can upload this on YouTube, I'll put it in the comments so you can read about MRKH. Basically, yes, it you can treat it without surgery. Not in all cases, just depends how much depth is present in the vagina. And if conservative management, which is pelvic floor therapy, especially dilation treatment, doesn't work, then surgery tends to be the only option to be able to have insertion for sex. Yes. So that is the other question I had. I'm just going to look at my computer for the last question we'll be addressing today. And this is a very, very wonderful question from a occupational therapist. She asks, Marianne asks, as a practitioner wanting to go into pelvic floor, what is the best way to gain a mentor while also working in a clinical setting? A lot of clinics prefer I have experience with pelvic floor. I also don't feel comfortable doing internal work without mentorship despite completing Herman and Wallace level 1. Wonderful question. So Marianne, I would say reach out to practitioners in your locality and ask them if you can shadow them. Sometimes, and I have done this myself, I found a clinician I wanted to shadow because I appreciated their skills, and I took a vacation. Took a week and went and watched them treat in their clinic Monday through Friday. So do that. Learn from them. Of course, you have to find the good fit. You have to find someone who will let you into their treatment space, let you watch, let you ask questions and answer them. A lot of clinicians will charge for this because it does take time away from things they could be doing in their own office space to work with you. So some clinicians don't charge a fee, some do, and find one that you like, whose treatment style you like, go visit them and shadow them. That really is the only way to do so. Also, specifically because you're an OT, Marianne, I will say this. As an OT, yes, depending on the curriculum, on the coursework at your university, you may or may not have had extensive training in the pelvis and hips. If that is the case, then you really have to double down with the anatomy, get that down pat. You need to know the musculature, you need to know the skeletal prominences, you need to know which way the muscles run to get some confidence. right? So double down on studying your anatomy, making sure you're right on you've got it. Revise your Herman and Wallace level 1 coursework and find a clinician. Have a couple conversations on the phone with them. You may have to pay them a fee, because honestly this is someone who's taking time out from their life to coach you, and that is worth something. Their expertise is worth value. And yes, if try a couple, even don't go with the first person you come across, and follow through with someone who you really connect with, and you will gain experience by doing. Oftentimes some clinicians will rack up a number of courses before they feel confidence taking it, and if that works for you, hey, that works for you. Honestly, I began treating after I had done my doula certification. I had a good understanding of the physiology of birth, how birth goes, what to expect postpartum, the changes that happen in a woman's body. I took Herman and Wallace 1, and I had done a couple courses on MedBridge, and that I thought was enough to start treating internally. And remember this, as a clinician, you always know more than the person in front of you, at least for the problem that you're working, or I hope you do. And if you don't do that, and you just tell your patient, I'm sorry, I don't have the answer for that, but I will find one for you. And it is a learning process. I am a much better therapist today, 3 years in, than I was when I started in pelvic health. At the same time, I helped so many people when I was starting out. So that hesitation to start is going to be there, but you have to dive in. There is no easy answer to that. I hope you find a good mentor. That was a great question. Thank you. That is all we had for today. So today we answered 4 questions. For anyone listening in, be sure to rewind. I'll try it and tell you in sequence. The first question we answered was bedwetting in children. Can it be related to pelvic floor, and if pelvic floor therapy can help it? The second question we answered was, how does one start working in pelvic floor? The third question we answered was, when to start diastasis rehab. The fourth question we looked at is, what is MRKH syndrome? And we talked about that. And lastly, we talked about how to find a good mentor and how to find confidence in starting off with doing internal treatments. So once more, I hope this was helpful. We answered those 5 questions from 5 different people. I know at least 2 other students had reached out asking some similar questions, so I hope you got your answers too. It was lovely being here, and I hope to do this again soon. I don't have a set schedule. As the questions come in, I'll pop on here and answer them for you. So thank you again for watching. This is Sujata Martin at Concierge Pelvic Floor here in Tampa, Florida. I also treat people virtually. I'm very happy to connect with you. I do believe as an occupational therapist, I have a different lens when looking at pelvic dysfunction. So if you've worked with a pelvic floor therapist already and feel like you made some progress but you're not where you need to be, or you have issues in the realm of sexual concerns, intimacy concerns, you have chronic pain that is not getting addressed, please reach out. Those are my specialties: chronic pain, sexual issues, and giving people a second go at pelvic floor. So thank you again for tuning in. I will see you all soon. Bye-bye. Okay, oh, I am sorry, technology problem. I just saw this, so I will answer it. The question goes, do you think there might be a reason for a 5-year-old to see a PT, I will rephrase that, to see a pelvic floor therapist, if they have only one nighttime accident, or if they wake up to pee every night? Honestly, maybe. Why is this child waking up every night to pee? So it's great that they have the sensation enough to maintain continence, but clearly something's going on in that they feel the need to wake up at night to pee. There could be some underlying constipation, there could be something going on. So yes, definitely reach out. I don't think, because this child is able to stay dry, I don't think it's going to be an extensive process, but you may get some answers by talking to a therapist. I hope that helps.